Okay.
Hey everyone, welcome to the Sports Docs podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
So today we're doing something a little bit different. So we thought we would dive into some of our most popular questions that we've gotten from some of our listeners and answer those kind of off the fly today. So some of the messages we've gotten either to our email or on Instagram or on Twitter, we're just going to discuss those and kind of give you our opinions. So as a reminder, you can find us at the Sports Docs Pod on Instagram and the Sports Doc Pod on Twitter. And you can send us a direct message with any questions that you have or any ideas for future topics you think we should cover. You can also email us at thesportsdocspod@gmail.com with any questions, and we will cover them in these mini episodes. So without further ado, I'll go to Catherine for our first question.
I know you have to do all the hard stuff. Say all like the Twitter and the Instagram and the email. I get the stuff.
I have it memorized by now.
Thank God for you. So we basically have been getting questions and we usually sort of respond to them individually, but we've just decided to make this a segment. So the first one I have pulled up that we're going to review. So this is we're just going to use first names from Jenny. She is in Nashville. And so she wrote in and wanted to know, okay, if I'm having, and she's a physical therapist, if I'm having patients after knee surgery with a lot of anterior knee pain, like what are you seeing other therapists do? What are some tips and tricks that, she can do and employ with her own patients to sort of reduce that, make it better? And then also, is that something I have to worry about? So what do you think? I know we probably have a very similar response, but what do you think, Ashley?
Yeah, I think this is really a really good question because I think we've covered it a lot, specifically with ACL. So the episode that kind of pops out to me is the one with Candace, where we spent a lot of time talking about anterior knee pain after ACL. And she actually taught me something, that kneeling desensitization, that now I tell all my patients about. It used to be, kneeling may hurt permanently after this. And it's like, no, like you can desensitize yourself. You can work on that. And that's what she does, partly as a physical therapist. So I guess for me, the two big things I really focus on are obviously quad strengthening. So if they're not doing blood flow restriction therapy, even if it's late in the game, I include some blood flow restriction therapy. I think it's really useful to lead to quad gains and address atrophy even late in the game. But the most important part about it being it's under lower stress loads, right? So it's lower loads, lower 1 rep max. So you're not putting as much stress through that joint that's already inflamed. And then the other thing is patellofemoral taping or KT taping. And you and I actually wrote a paper about this when we were residents. I don't know if you remember that.
Yeah, I do.
Yeah. And so I tell patients all about that. They think it's so cool when I show them a paper that my name is on. And talk about how there's different techniques for KT taping. The exact techniques are a little outside my area of expertise, but our PTs are really well versed at it. So I definitely write that on the prescription and advise that they give that a try as well. But I'm really excited to hear what you think because you're PT trained. So I'm really curious to hear what tips and tricks you have.
I think, I definitely look at what is their patella doing? Is it maltracking? Do they need some assistance with KT taping? And I would say even since we wrote that paper, definitely since I was a PT, the techniques have really evolved. So I don't even bother to try and say, hey, they should tape it this way or that way. It's just your therapist knows a lot better than I, but it's worth trying. There's really no downside. So that's something that I'll definitely start with. But then I also give them a lot of education about what happens to your knee when it's fatigued versus when you feel like you have a lot of fuel in the tank. So when I see someone at 6 weeks after surgery, I give them the same sort of spiel, which is basically all right, you are about to enter what I would refer to as the endurance phase. You're going to start to work on increasing your standing tolerance, your walking tolerance, all the tolerance for all your daily life. And undoubtedly, you're going to overdo it. You're going to do too much. And generally, you're going to feel anterior knee pain, achiness, that kind of stuff. And it's generally because your quad got tired. Your kneecap's not tracking as well. And then sometimes I also see people get adductor pain and they think it's just medial knee pain. Did I tear my meniscus? Did my meniscus repair fail? Something like that. And it's often as their quads get tired, their adductors are trying to take some of the load, but they're not great at it. So I think that's part of the thing.
To do that.
Yeah. And I think, so some of it is all right, are you finding a balance between your workload and your recovery? So I think if they're getting that sort of anterior knee pain, sometimes they're under recovered. So, does that quad have enough fuel in the tank? To build that tank, we're going to do BFR, we're going to strengthen, but then also are we sort of overdoing it? And usually the overdoing it is the boring stuff. It's I went to a restaurant or a bar and I stood too long. I went to Costco and I stood too long. It's not your workout's too hard. It's like all the other, I don't know. But that's kind of where I sort of hit it. But then there's also like late stage anterior knee pain. If they're getting it like 8, 9, 10 months out, then I think we're starting to deal with like, all right, how are we with soft tissue mobility? Like, how are we with our, like more of our, just like our functional movement patterns. When you're doing a single leg squat, like, do you look like garbage, or do you look okay? So I think it depends on the period of time.
I completely agree. I think looking at the whole kinematic chain is really important. If their hips are weak and their knee is going into dynamic valgus, that's putting stress on the patellofemoral joint. So I think doing some of those movement analyses that you do in your clinic, I think is really beneficial because I think that can identify not always or oftentimes it's not the knee. It may be flat foot, dynamic flat foot. It may be the hip. It may be the whole sequence. So it definitely could be something above or below, the pathology. Something that it was Jenny, right, that asked this question. So something that Jenny asked you is like, is this normal or is this to be expected? And I think that brings up a really good point that we as physicians need to be counseling our patients that this, I don't say normal, but can be expected and is part of the recovery, especially in the setting of ACL. I had a patient the other day she told me as a second opinion, had an ACL done somewhere else. The ACL itself was done well, but developed arthrofibrosis, underwent a lysis of adhesions, has gotten back some motion, but it's stiff, limited patellar mobility, and has terrible patellofemoral crepitus, right? She tells me she was never told. She was never told to expect anterior knee pain or anything like that. And she's not the first to say this to me. We need to be telling people it's going to hurt to kneel. You're going to have some patellofemoral crepitus after ACL. You have to work on patellar mobilizations because when you tell them at the 8 and 9 month mark, like it's a little too late, right? If you tell them to expect it and work on it, then it's less shocking and they have more, I don't know, hope or effort or readiness to like work through it with their therapist rather than feeling defeated. So I think that's really important.
No, I think it's just like anything, like setting some expectations, like understanding the expected course of recovery. And that's like exactly why at that 6-week visit, I like counsel them and say, you're going to get achy. You're going to have some bad days. Don't freak out. You just have to like problem solve with PT or just know that you're a little under recovered. But
absolutely. And I think something you said too about like the overuses, I'm sure you tell your patients this, every phase that you advance, something like you get them out of the brace or you start running progression or you start agility, like they're going to have more pain. Like they, at the start, they would all call in and be like, did I do something? My knee swelled up a little bit. No, just that now you're running and you haven't ran for 4 months because I started at 3 months and you haven't ran for at least the month before surgery. So it's a lot of stress on your knee and you need to, expect that, and it can be normal and it does get better.
I always think like Candace says something to her patients too, where she always talks about like, it's like peeling back an onion, like, every stage more stuff comes out and like you get through it, like you get to the other side, but it's not just like it always gets better. It just gets different. And then, and then at some point it's better, but it's a long haul. But hopefully we've answered all that question very well for Jenny, but I think that's a really popular one. And then I will also on the YouTube channel, like flag back to that episode with Candace on ACL recovery, because it's still one of our most popular downloaded episodes. A lot of good nuggets in there.
Yeah, it's really awesome. I reference it all the time. I send it to all my patients when they have questions about what the rehab is going to look like and what to expect. So really happy Candace was able to join us on this.
Me too. Awesome. Okay. Do we have time for one more? You want to do one more?
Yeah, let's do one more. Are you one of the many surgeons who thinks that getting osteochondral allografts is a complex and time-consuming process? Well, you're not alone. But we're excited to tell you that there is a simpler way.
At JRF Ortho, they get it. They've heard your concerns and made it their goal to simplify the process. They're not just any company. They are leaders in fresh osteochondral allografts, holding over 60% of the global market share.
JRF Ortho is committed to accommodating your needs, delivering allografts usually around 30 days, and it's all on your terms. You choose your scheduling option, whether it's specifying a surgical date, providing a date range, or just requesting the earliest available allograft. Your preferences are their top priority.
And there's more. They offer pre-sutured tendons and meniscus, and ordering is as easy as a few clicks on their user-friendly online ordering system.
So why make it complicated when you can make it JRF Ortho easy? Simplify your allograft procurement today. Your journey to seamless osteochondral allografts starts with JRF Ortho. To learn more, visit jrfortho.org. All right.
So I'm just pulling it up now. So I think the other question, okay, so his name is Gary. He is from Indiana, and so also a physical therapist. And he was wondering,
We love our PTs.
Yeah.
We love our PT audience. Keep on listening and sharing.
He feels like, at least in his area, there's like a lot of conflict and sort of divided lines on BFR. Like, when do you do it? Is it like okay to do it early? Do you have to wait 6 weeks? Like, he's kind of seen a lot of different things out there and kind of want to hear our opinions. So what do you have to say to Gary?
So I have no hesitancy to use BFR. I think it's a really great modality. I use it in my non-operative patients as well as my surgical patients. And surgery-wise, I honestly, I'm going to follow this up with, I don't know why I do this, but I do a wound check first to make sure it's healing well before I do BFR. And you're just like, why? And it's like, well, do you compromise wound healing? I don't think so. You're not really depriving, you're not depriving all the blood flow. You're depriving 80%. You're still maintaining 20%. So I don't really see why that would be an issue, but that's what was listed as a contraindication. So I do it. But I started as early. First off, I do it preoperatively. I should start with that so that patients know what to expect after surgery. And then I started after 2 weeks. Once I've done that check and removed the steri strips and everything looks okay, that's when I'll start blood flow restriction therapy. I use it in pretty much all of my knee surgery patients, but especially like my ACLs, MPFLs, TTOs, like the major knee, cartilage, exactly. Because I think it's really important to activate that quad early. Like I used to say, it's a marathon, not a sprint. You get back your motion eventually, and it really matters. Like you get back your motion quickly and your strength quickly, your rehab is all easy peasy. But like if you struggle with that, it really can hold you back from all the other things you want to do. So I'm a big fan of BFR. And this might be controversial, I even use it in skeletally mature individuals. Because for me, if I'm going to use a tourniquet for an ACL and a 14-year-old and have it up for what the max time is, 120 minutes, I'm usually not going anywhere near that. But if I'm going to do that, why am I not saying that, 1 to 2 minutes of blood flow restriction therapy is going to compromise their growth plates? I don't see that rationale.
Yeah.
What are your thoughts?
Agree. Yeah, same. I would say even when you think about the wound kind of healing thing, a lot of times people in those first 2 weeks can't tolerate BFR anyway, just because they're so like overwhelmed by all the initial stuff. And they're just trying to get their head around like, how do I do extension flexion? Like all the basic sort of stuff. But if like a patient came in and said, oh, was I supposed to do it? We did it post-op day 3. Are you upset? I'd be like, no, I've never read anything that definitively says like that's going to give us wound issues, but I totally get why theoretically we're sort of like, okay, a little caution there and make sure it's wound, it's healing well. But I have to say, I can't say I've seen many people who could tolerate it in the first 2 weeks. So
that's true. Yeah.
You know what I mean? So it's probably no big deal. But yeah, big fan. I can't remember if I've told you this before, but we've talked about this on the podcast before that I've operated on my nieces for their ACLs. And that was like their Christmas present. It was like, hey, I just, Aunt Catherine bought you like a BFR unit. Because I just wanted them to be doing it. And I'll brag on Peyton, who is like, she's like a year and 9 months out or whatever. And she is now like back doing college, like triathlon and stuff. And it's just like crushing it. And I look at her legs and they're so beefy. Like she did an awesome job. Like she's so lean and fit and she's got great, leg strength. So I attribute a lot of that to the BFR training for sure.
Absolutely. Yeah, I think it's really important. Have you tried it yourself?
Totally. So we own a unit.
That's awesome.
So I have it so in our like home gym, we have it. So part of it was like, all right, if I'm making my nieces do this, like I need to sort of like do this. And it is hard. It's really hard.
So hard. Yeah. I was so surprised. And that's kind of a big plus of doing it pre-op is that people know what to expect post-op. It's not that it's hard because they're post-op and their quad is inhibited. It's hard in general. And, it also makes me sympathize for my patients. Like what I did, I did both the leg and the upper extremity, but even like the biceps BFR, I was just like, okay, I'm done. That's okay. I'm hearing what you're saying and I get it now, but I don't have to do it anymore. But it's really challenging, but you definitely see the benefit of it. So I think it's really great.
Sure. Especially cartilage, like when we're doing, when they're, just depending on the protocol, if they're not fully weight bearing, I think it's just a great way to hypertrophy. So yeah, I love it. So keep doing it. I don't know. It's new. And I think anytime something new, it's hard to integrate that into a new community. Even when I came to Denver, like I felt like it was a little spotty. And then just over the last, 6-7 years, like you just see it populating a lot more around clinics. So I think part of that is just like, making sure whoever is implementing it has great training and that you're actually using, safe technology.
Absolutely. We did a whole episode. We should actually link it here with Eddie Chang on BFR, like a whole 2-parter, which I think was really good because we talked about exactly what you just highlighted, which is like making sure it's good equipment, it's standardized. So like there's guys you'll see working out of the gym just tie bands around their biceps, so like around their thighs. Like that's not blood. It is, you are depriving blood flow, but it's in an uncontrolled manner. Like it needs to be based on blood pressure and how much you're trying to occlude. And it can be dangerous if not done correctly. So I think that's really important. Definitely making sure it's done correctly and under the guidance of a physical therapist. But yeah, I think it's really beneficial, especially for the non-weight bearing conditions that you mentioned, like cartilage or tibial tubercle osteotomies. I think that's really beneficial.
Yeah. So hopefully, everybody got a lot out of this episode, and I hope people write in more and we'll try and address your questions, or find someone who knows the answer if we don't know the answer. And, I don't know, any other thoughts?
No, I think that's great. I like these questions, so we should definitely do more of these. Hey there, fellow surgeons. It's Dr. Ashley Bassett
and Dr. Catherine Logan. We're thrilled to share what we think is the next frontier in orthopedics with you.
Absolutely. In our sports medicine practice, we're always looking for innovative ways to enhance our patients' recovery journey.
That's right. And that's why we're excited to talk about accelerated recovery, or XR for short. It's a perioperative recovery supplement that's been a game changer for us.
XR is surgeon formulated with clinically researched ingredients at optimal effective doses. It's designed to support wound healing, prevent muscle loss, and speed up return to functional recovery.
Totally, Ashley. And that's where XR comes in. At my clinic, we've implemented the XR nutritional optimization recommendations as part of our standard of care for patients, and the results have been really exciting.
Absolutely. I recognize that our patients' nutritional status has become an increasingly recognized risk factor for surgery. Malnourished patients face risks like delayed wound healing and infections.
Just recently, I had a high-level athlete I operated on who went through a 3-week XR recovery program. The feedback was really exciting. He had faster healing, minimal muscle loss, and overall a smoother recovery process.
And I had a similar experience. The ease of implementation and the positive impact on patient outcomes have been really motivating to continue to study.
And I tried it too. XR is a cranberry lychee drink mix. It's sugar-free and vegan, and it's safe for anyone over 12 years old.
So, fellow surgeons and healthcare providers, if you're looking to elevate your patient's recovery journey, consider XR. Let's embrace the future of targeted nutritional supplementation together.
Visit xrscience.org or xrscience.org to learn more and join us in revolutionizing perioperative care.
Well, thanks everyone for joining us for this mini episode of the Sports Docs. We hope you enjoyed this kind of off-the-cuff discussion Catherine and I had answering some of the questions that you sent in. Please send us more questions. We really like doing this, and we definitely want to know what you as the listeners want to know more about. So please send us your questions. You can DM us on Twitter and Instagram. You can also email us at our Gmail, which is thesportsdocspod@gmail.com. You can also find us on YouTube as well too, and comment and subscribe there. So we love your feedback. Reach out to us any of the platforms, and we'll see you later. Yeah. Take care. Bye.